Good afternoon or good morning, everyone, depending on where you may be joining us from today. And welcome to the Child Neurology Foundation's 2016 webinar series, Child Neurology Community Conversations from the Voices of the Provider, the Parent, and the Advocate. My name is Stacia Grace, and I'm the Director of Operations here at Child Neurology Foundation. On behalf of our Board of Directors and Corporate Advisory Partners, we are excited to bring you this latest episode of our webinar series that will discuss the evolving topic of the use of medical cannabis in the treatment of epilepsy. We are incredibly pleased to have a panel of experts with us today to help us better understand the consensus as well as the divergent perspectives on this issue. Before getting started, I wanted to briefly highlight who CNF is for those just learning about us, as well as touch on our work to support youth, families, and clinicians in the child neurology community regarding the use of medical cannabis for epilepsy. CNF is a national nonprofit, and our mission is to serve as a collaborative center of education and support for caregivers and their children living with neurologic conditions. In particular to our medical cannabis and epilepsy education efforts, CNF conducted 2 surveys in September 2016 to help further understand clinician and caregiver perspectives on this topic. 167 child neurologists and almost 500 caregivers responded. The findings of the survey were then presented at CNF's annual symposium at the 2016 Child Neurology Society Annual Conference this past October in Vancouver. The survey findings highlighted the divergent opinions of these groups on the subject of medical cannabis, while also illuminating that both desire to be better prepared to discuss this topic with the other. Parents sought to understand how to approach the clinician and vice versa. So we hope today can showcase the possibilities of such a dialogue. CNF would like to thank our corporate advisory members as sponsors for today's call. And just a few more things before we get started. Each of our presenters will speak for approximately 15 minutes. Feel free to send in your questions via the chat function. We will pose them to our panel at the end of the call. We want to hear your voice as well, and asking questions is a great way to share your perspective and engage these experts. So with that, I'll introduce our first presenter, Dr. Anouk Patel. Dr. Patel is board certified with special qualifications in child neurology, epilepsy, and clinical neurophysiology. He is an associate medical director for Partners for Kids, the nation's largest pediatric accountable care organization. He is the director of the Complex Epilepsy Clinic. He is an associate professor for neurology and pediatrics at Nationwide Children's Hospital and the Ohio State University Medical Center in Columbus, Ohio. He has journal publications and clinical research interests in the fields of pediatric epilepsy, healthcare utilization, and quality improvement. Dr. Patel, welcome, and thank you for your participation in today's webinar.
Thank you, Stacia, and thank you to the Child Neurology Foundation for having me today in discussing this very important topic. So I'm going to take the advantage of being able to discuss some of the data that's out there and some of the other evidence, and address some of the questions and things that we need to do moving forward in this ever-growing and changing field. As Stacia said, this is who I am as listed on your slide, so I won't go over. It's important, though, I mention that I do have some disclosures, and they're listed here as follows. And to go ahead and get into it, I want to set the tone and table by discussing some definitions. I think it's very important that we set these definitions so we all have a clear understanding of the terminology that's used in this field. So when I refer to medical marijuana, what I mean and what the field usually means is it's defined as whole plant marijuana or cannabis that's used to treat disease or alleviate symptoms of a disease. Cannabidiol, or what a lot of people know as CBD, is a prominent, not the only, but a prominent non-psychoactive, which means it does not tend to get people high or give them euphoric properties component of the cannabis plant. And in fact, it really has low binding to the CB1 and CB2 receptors, which are the receptors that we feel in medicine and science that do allow the euphoria or the experience of getting high, which allows for this medication or drug in the sense of THC to be used for that purpose. So let's go over some of the current evidence that's available that we know based on the literature. Now, there are a lot of medical reports and anecdotal evidence on certain illnesses within the medical field. Here's a list of some, but by no means a conclusive list, and you've probably been aware of some of the literature as it relates to some of these disease states, and some of them have also led to some synthetic products that are currently available and can be used as well for these disease states. Now, what's important and what's interesting is let's focus on the epilepsy evidence. And when you look at the evidence as it relates to just the field of pediatric and adult epilepsy, it's important that we know that what I'm going to talk about on this slide is the evidence as it relates to one portion of the plant, which is cannabidiol or CBD. As we talked about before, that's the non-psychoactive version. These studies I'm talking about were done by a company called GW Pharmaceuticals over in Cambridge, England, and basically they have a purified plant-based product that is 98 to 99% CBD, which is counted as purified. So it's as close to the pure CBD product as you'll ever get, and it is plant-based. There is a synthetic version made by a different company called Innis, but I am not able to talk about those results because none have been published thus far. And really what I'm focusing on are published data that's in our medical literature that we as medical providers use on a regular basis. So in 3 studies I'd like to highlight. One is the first one, and I was a participant in this study, in most of these studies, and what we did was we got use of Epidiolex, which is the name brand version of this cannabidiol product, and we're able to use it in what we call an open label fashion, which means that everybody who was eligible for this population and for this medication was able to get the medicine. So there was no comparison to a group that did not get the medicine, which is what we call placebo, and I'll highlight that later. And basically what it was shown, and this has been published in Lancet Neurology, is that about 45% of the patients had at least a 50% or more reduction to seizures. Now, we do not feel these are gold standard or what we feel is the best evidence, only because it wasn't compared to a non-active product where we call it placebo. So that was the next phases of these studies, and those have now had data that's either been published or released for public view. And what you'll notice about these 2 studies, they are in specific disease states. One for Dravet, which is a specific form of epilepsy that often presents with very difficult to control or what we call treatment-resistant epilepsy. And then the other, and there are 2 studies that have been released for publication or at least comment in the public arena, are for Lennox-Gastaut syndrome. Now, for those that aren't familiar with Lennox-Gastaut syndrome, Lennox-Gastaut syndrome is a combination. To make this diagnosis, you have to have more than one seizure type, a delay or loss of learning and learning skills, and then a very specific or certain EEG pattern. And there are certain treatments that are used and FDA approved for this, and Epidiolex was studied in this realm as well. It doesn't give you a specific reason of why you have epilepsy like we say in Dravet, but in Lennox-Gastaut it could be from a lot of different causes. But what you saw in these studies was very interesting information that showed very similar results to what was seen in the open label study, that many of the patients had a benefit of at least a 50% reduction or more of their seizures. And that is really something that's similar to other medications that are currently available that are FDA approved. The data is either the similar or even potentially slightly better, but by no means was an absolute benefit to every participant in these studies. Now what's interesting is they are actually able to decide how much benefit do the patients get from getting the medicine compared to those who thought they might be getting the medicine or not. So everybody in this study, both the person getting the medicine and the provider giving the medicine, had no idea if they were actually on the product, meaning the Epidiolex, or this placebo. So it's a very good way to compare what really is occurring in these patients as it relates to the medicine or treatment that's being given. Now, it's very important that we talk about side effects that have been shown in the studies. And all studies had similar reporting of side effects. And in if you kind of put all the patients together, over 75% reported a side effect from this study. Now, I will tell you in the placebo-controlled studies, there were a high number of people reporting side effects as well. And the most common side effects that were reported are nausea, diarrhea, sedation. Now, there might be a possible drug-drug interaction between this medicine, Epidiolex or cannabidiol, versus when interacted with clobazam, which is the trade name as Onfi. And there might be issues as it relates to increased liver enzyme for those that are on Depakote or valproic acid. Again, a lot of this analysis is ongoing and further information will be available in time, but that is something that we have to consider. And it's important to remember that it's a very good point here to say that there's nothing natural about plant-based medicines or therapeutics. They are as potentially harmful and dangerous as anything else. Just because it comes from a plant does not necessarily make it safer. Everything needs to be broken down in your body, and plant-based medicines and therapeutics are done the same way. And in this case, marijuana or cannabis or derivatives of cannabis, products such as CBD, etc., are all broken down in your liver. And therefore, it's important to know what other medicines are on. And we'll talk about that as we wrap up this portion of the webinar. Now, what about outside of just CBD? Unfortunately, there's not a lot of published medical literature that can support or go over the use of these products. However, there was an Israeli study that looked at a CBD-enriched portion of cannabis. And what they did was took a ratio of oil that was 20 parts CBD, which is what we talked about earlier, versus 1 part THC. And THC, remember, is the euphoric portion of the plant that binds to those receptors I mentioned earlier that does allow somebody to achieve or feel high or euphoric, and then that's why a lot of people use this for recreational or abuse purposes. And in this study, they took 74 kids between the ages of 1 and 18 and dosed it as follows, between 1 to 20 milligrams per kilogram per day. And all these children had to have a similar treatment-resistant epilepsy, which means they have failed at least 2 trials of medications and have still having seizures, very similar to the open-label phase or the expanded use phase that I mentioned earlier as it relates to Epidiolex. And the way they recorded seizures or seizure improvement, it was based on what the parent had observed at baseline and as the patient was given this product. And the results were really similar to what you saw in the cannabidiol-only studies, as I mentioned earlier. The differences are here as follows. So 7% reported an aggravation of seizures, which actually led to the medicine, in this case, the combination or the ratio oil of 20 to 1 to be stopped. And that might be because there is some literature and some animal data that suggests that THC is either neutral as far as its properties of controlling seizures, or in some cases, some animal studies have suggested that it actually is a proconvulsant, which can lead to seizures. So the jury is still, unfortunately, out in this regard. However, what they did also observe was some improvement in behavior and alertness and language and communication, which was also seen in the CBD-only studies as well. Side effects were very similar to what I reported and also at the similar percentages as I reported earlier. So not much different. So what don't we know? This is what we know, but what don't we know? Well, I think it's really important that we clearly state that we really don't know about what is out there, meaning the available what we call vernacular products, or products that you could purchase either in the state of Colorado or other states that have legalized marijuana or marijuana-type products, is that we're not quite sure what's in them. There's no jurisdiction or regulation that they say they have to have what they claim to have in it. And a recent study showed that when testing products that claim to have CBD or the cannabidiol, actually 50% of these products that are commonly sold throughout the United States actually had 0 when officially tested. So I think we don't know what the validation of these available products. We don't know right now, at least, what other disease states outside of epilepsy that these products or similar products could be useful. I also believe we need to know more about why or how CBD or CBD-type products or THC and medical cannabis-type products work on the human brain, and specifically to help treat those that suffer from having epilepsy. And then we also want to know more about the negative effects on the developing brain. What's interesting and what's important to consider is that we are potentially giving these products to children. Well, children have obviously brains that are in development, and what we are seeing with regards to THC and not CBD is there's potential harm in that regard, and so we therefore have to study that a lot more clearly before we can advocate or recommend its use in pediatric population. There's a really interesting manuscript that's coming out in pediatric neurology. In fact, it may be online currently, that did show some pathology changes to a young child that grew up to be an adolescent and unfortunately passed away, and his brain showed chronic changes because of the marijuana use. So it's important to know further as we move on. What we need? Well, we need more data on does this medication work, and specifically which populations within the epilepsy world does it work or doesn't it work in, or what potentially is it could make seizures worse or, and again, make it better. We also need to evaluate what other chemicals from this plant may have a therapeutic effect, which means what other parts of this plant could have benefit to our kids and adults who have epilepsy. And we need to provide those answers for basically for patients and their families and caregivers. It's really important that we in the medical community fight very hard to figure this out so we have clear answers that can be given to our parents who are in desperation and need at this point. What does it mean for you? And I'm going to break this down as far as providers, which is where the world I live on, and I think some that are on this call may live in that world as well, but then also from the caregiver patient perspective. When we look at medical providers, well, you know, the reality is that we are in a world where we need to have good evidence, and unfortunately right now we can only know that FDA-approved products are reliable, or if a product is FDA sanctioned for study, that it's reliable and consistent from month to month or batch to batch, or from medication to medication. And I think that's an important problem that we suffer because we want to be sure that what we recommend to our patients is actually what they are actually getting. It's also important for medical providers to know that currently it is illegal to prescribe federally, although you may live in a state that has legalization for marijuana, either for recreational, medical, or both. It is still legal on the federal level. State laws right now do not require consistency of products. We hope that in the state of Ohio that law, once enacted, will actually require that of these products, because I think then we could have some good comparisons on what's important and what's actually in these products. Right now we're not quite sure exactly how to dose these products. You know, I think it's still, the jury is still out, the studies are still ongoing, and so it's important that we figure that out more, and also fully understand the side effects or potential drug-drug interactions between marijuana and marijuana-type products or cannabidiol or other components of the plant as it affects or relates to other seizure meds or other non-seizure meds. As I stated earlier, nothing is natural about what we're doing, and therefore it's important, even though it comes from a plant, that we understand exactly how it interacts with the human body. For parents and caregivers, you know, I hear it every day, and I take care of kids with treatment-resistant epilepsy that aren't candidates for surgery, and so I hear and see their patients are running thin, and we need to know more about what's available and what's safe. Unfortunately, you know, CBD or thus far cannabis is not proving to be the holy grail. You know, there's a recent study that showed that many patients in Colorado who are given, or originally were given, the Charlotte's Web product or cannabidiol products in the state of Colorado are actually not even staying on it over a year, which suggests that perhaps it's either having some side effects or it's not as effective as it's hoped. You know, I wish every day there's a magic bullet in my field. I always wake up and think that I treat epilepsy, I don't cure it, and one day I hope that I'll have something that can cure it. But unfortunately right now we don't have that for everybody. I think there are parents who express and caregivers that there are some concerns. I've heard that from many of my parents, that they're very concerned about giving these unknown products to children that they can purchase either on the internet or through these stores or dispensaries. And again, there's nothing natural about medical marijuana. I think that's one of the big fallacies as it relates to this, that because it's a plant-based therapeutic, that it's somehow safer or natural compared to other things. There are many medicines that have been developed by plants, but we would not ever think those as being natural, such as digoxin, which is given for a heart arrhythmia. And we're also, I hear from my parents and caregivers, and I also fit in this regard, is that we're very hopeful that perhaps an FDA approval will be coming. And that, I think, will help us to know what's out there, what's safe, and what's consistent for our parents. So in summary, I think more research is needed. We're on the way, and those studies are ongoing in epilepsy, and I've been fortunate to participate in that. And hopefully an FDA evaluation will occur soon, and that for then will lead to an approval based on the data that's been so far collected. And I would really caution those out in the public to be very careful of the available products. Be sure you know what you're getting. Have it tested if possible. We're going to talk a little bit more about that, I hope. But reality is that it's important that people know that there is no requirement or law that says that these people have to make products that say what they're on the label, and that's important for us to know. And it does appear that our DEA, Drug Enforcement Agency, is appearing to loosen and allowing more research, which I think is very much needed and will help this field move forward and finally give us and our parents and caregivers and patients the answers they desperately need as it relates to this important topic. So with that, I'll go ahead and conclude. I want to say thank you again to the Child Neurology Foundation and for those that have listened. And we'll do some questions via the chat at the end. Here are my references in case anyone is interested. And now with that, I will turn it over to our next speaker.
Thank you, Dr. Patel, for that wonderful overview of the science and the research. And I think it's a really great foundation for what Katherine is about to talk about from the parent perspective. Katherine Jacobson, Dr. Katherine Jacobson, obtained a PhD in neuroscience from the Oregon Health and Science University and completed postdoctoral fellowships at UCSF and Stanford. In 2013, Dr. Jacobson published the first account of parental treatment of pediatric epilepsy patients with medical cannabis in epilepsy and behavior. The publication of this paper was motivated by her own experience of attempting to treat her son's severe treatment-resistant epilepsy with cannabis preparations. Her personal and professional experience in this field led her back to UCSF, where she set up the first compassionate access program for Pure CBD, which is GW's Epidiolex, for children with severe treatment-resistant epilepsy. Her work now focuses on tackling practical and scientific challenges facing medical cannabis clinical use and research, with the ultimate goal of generating the information physicians need to make informed decisions about patient treatment, as well as the information that policymakers need to make informed, thoughtful decisions on policies that will govern not only access for research purposes, but also access for patients. Katherine accomplishes this work as the Director of Clinical Research at Tilray, a Canadian medical cannabis provider licensed by the federal government. At Tilray, Dr. Jacobson is responsible for organizing clinical trials to advance scientific understanding of the therapeutic potential and risks of medicines derived from cannabis. She is currently working with researchers at a number of hospitals and universities on trials involving Tilray's pharmaceutical cannabinoid products. Dr. Jacobson, welcome, and thank you for joining us today.
Thanks so much, Stacia. It's a pleasure to be here, and thanks very much for hosting the webinar on this difficult topic. Your introduction was wonderful, and it saves me from going through some of my background and what led me to this job. And I'll just echo a lot of what Dr. Patel said, which is that there's a difference between the artisanal preparations that are out there and the pharmaceutical grade preparations. And it was my experience, as Stacia said, in treating my own son with artisanal preparations back in 2013 that led me to this position as Director of Clinical Research at Tilray, where we can be another company like GW Pharma that produces pharmaceutical grade preparations in order to do the clinical work that we need to do to understand the therapeutic benefits and risks of these medications. So first, let me just talk about THC and CBD, because these are the two best known cannabinoids in cannabis. And you can see that structurally they're very similar, and they're in fact very, very difficult to separate chemically. And the reason I make this point is because later I'm going to come back to artisanal preparations that claim to be cannabidiol, but that always contain some amount of THC in them because the chemical structures are so similar. So today I'd like to talk about issues that are relevant to the clinical discussion, and I'll focus first on what artisanal cannabis preparations are and why they're so different from the pharma-grade preparations that are used in clinical trials. I'll talk a little bit about data for informed treatment versus FDA phase 3 clinical trials that lead to approval, patient-centered care, and then we'll spend one slide talking about how we can improve data collection efforts and outcomes. So just to go back to Dr. Patel's point, when I was at Stanford in 2013, that's when I first heard about parents who were treating their children with medical cannabis. And it was confusing to me because as far as I knew, medical cannabis had hundreds of compounds in it. And I was trying to figure out which of those compounds would be the most likely to be the anticonvulsant. And if you go back to the literature, there is a lot of supporting evidence that it's actually cannabidiol. And so cannabidiol is one active ingredient in the plant. And when you have a pharmaceutical preparation, the active ingredient is very well defined. And it's defined both in structure and in amount present. And so pharmaceutical preparations are all manufactured in accordance to ICH guidelines. These ICH guidelines govern, ICH stands for the International Conference on the Harmonization of Pharmaceutical Drug Products. And these standards are in place to ensure that any drug that is manufactured has an expiration date, and the company that manufactures it comes up with that expiration date by doing stability testing. And the ICH guidelines govern stability testing for each drug product that is manufactured and sold for use in humans. These ICH guidelines also have in place analytical validation methods, and this is really important because it means the company is responsible for making sure that each pill itself, for example, Advil, 200 milligram pill of Advil, in fact contains 200 milligrams of ibuprofen. And they put in analytical validation measures internally that ensure that every single pill leaving their manufacturing facility contains exactly what it's labeled to contain. These guidelines also govern the level of impurities that are allowed in pharmaceutical products. And the identity and the level of these impurities varies from drug to drug, and it depends on how the drug is manufactured, what the starting materials are, where the risks of these impurities come from. And that's really important when you think about medical cannabis, which I'll talk about in a second. But ICH guidelines also govern good manufacturing practices, and this is a company's responsibility to put in place quality assurance and quality control measures so that every batch of the drug that they make is identical to the others. So there's reproducibility and reliability in their manufacturing practices. It's a huge burden on a company to go through these good manufacturing practices standards, but it's in place to ensure that the drugs that humans end up taking are safe and not contaminated and accurately labeled. And so by following these ICH guidelines, pharmaceutical products then can be precisely dosed because they're labeled and they contain exactly what their label says. When you look at the artisanal preparations that are now being sold at dispensaries and over the internet, they are whole plant extracts, and they contain dozens of compounds, which in and of itself is not necessarily a bad thing, but they don't define the active ingredients in their preparations. And as I mentioned before, if you want to give a precise dose of a medication, you have to first be able to identify the structure and the composition of the active ingredient. So that's not done with artisanal preparations. And there's really no regulatory oversight in the manufacturing standards of these preparations. And it's surprising that these products that are actually considered medicines are falling through the cracks of guidelines set by the FDA for pharmaceutical drugs. They're not guided by regulations in place for dietary supplements. So anything that is sold on the shelf of a supermarket, for example, falls under some kind of a regulatory guideline for manufacturing that the FDA has set forth. But somehow, because medical cannabis has been legalized at the state level, these preparations really don't fall under any regulatory oversight. And this is a huge problem because if there's no regulatory oversight into product quality, you really can't do precise dosing. And if you can't give a precise dose, then it's very, very difficult to do meaningful clinical research. The very first piece of meaningful, methodologically sound clinical research is knowing what the patient is receiving. And Dr. Patel brought up one study that was recently published, and here are two other reports that just show how important it is that these products need to be regulated because they're completely inaccurately labeled. The Journal of American Medical Association in 2016 published a survey where they tested 75 products. These were done in 3 different states from 10 different dispensaries. And they found that 83% of these products were inaccurately labeled for THC content. 44 products had detectable levels of CBD, but 13% weren't labeled. I'm sorry, only 13 of those products were labeled for CBD, and 100% of them were inaccurately labeled for CBD. So this brings us back to knowing what's in the preparation, even knowing the identity of the active ingredient and the amount of the active ingredient that's present. The Globe and Mail is a newspaper in Canada that looked at 9 unregulated dispensary products, and they found that they were contaminated. One was contaminated with yeast and mold. 2 products contained microorganism counts that exceeded limits, and 3 products contained potentially harmful bacteria. So let me just explain what cannabis is and why it's so difficult to get consistent preparations. What you're looking at here are 3 different cannabis strain names, and I want to emphasize that strain names do not equal species differences. So different species can be called ACDC by a dispensary if ACDC is a high-selling product, even though the product they're selling is not technically ACDC. And that's common that these strains are mislabeled. But what you're looking at is the chemical composition of 3 completely different strains, and the pink bars represent the amount of CBD, the green bars represent the amount of THC in that strain, and those are the 2 most prevalent cannabinoids present. And then in the middle you can see that there are minor cannabinoids that are listed and also some terpenes that are listed, and they vary by content. If you do an extraction, so the most important point to make with this slide is that the chemical composition of the starting plant material varies greatly, and that's going to affect what comes out in the end when you're looking at an extract or an oil, which is most often what's given to children with epilepsy. So not only does the chemical composition of the strain affect what ends up in the extract or the oil, the extraction methodology has a lot of variables that determine which of these cannabinoids end up in the oil and how much of them end up in the oil. And the extraction methodology varies greatly from dispensary to dispensary and from producer to producer. Solvents are used that can often be present at dangerous levels in the oil. Heat settings determine which terpenes and minor cannabinoids are extracted from the plant. Vacuum pressure settings have a relationship to what ends up in the oil, and the time of extraction also has a big effect on what ends up in the oil. So you can imagine that getting consistency from batch to batch can be really difficult if you don't have the proper quality control standards in place, and if you don't follow the standard operating procedures, which are the guidelines for good manufacturing practices, if you don't follow those, you can imagine that from batch to batch, you're going to get high variability of the chemical composition of the oil. So now I want to switch gears a little bit and talk about data for informed treatment. We know that the gold standard for any FDA-approved drug is a randomized placebo-controlled trial. And these trials are designed in order to give answers to physicians about how to treat their patients. And they provide a lot of data. In this case, I think in the case of medical cannabis, we really have to be realistic and understand that we're in this completely unprecedented situation where patients have access to some form of this study drug already. And so my position is that while we need to continue with our FDA trials in order to gather the final clinical evidence on combination drug products for specific indications, there are ways in which we can gather data right now that will inform treatment, especially for patient populations that may not have time to wait for the 2 to 5 years required for FDA approval for specific products. And one example, the reason I'm giving Epidiolex as an example here is because so far that really is the only product from which we can get methodologically sound clinical data, because that's the only product out there that meets ICH guidelines so that we can get a precise dose. And from these Epidiolex studies, which Dr. Patel outlined earlier, we've already gotten a lot of information that, while it may not lead to FDA approval, really does provide a lot of information important in guiding treatment. So we know what the starting dose should be, we know what the titration schedule should be, we know what the response signal might be, we have information on side effects, we have really important information on drug-drug interactions and on adverse events. And this is the really difficult work that that companies who do clinical trials gather. The reason I think this is such an important point to make is that you have right now this proliferation of companies selling what they call a medical product, not willing to meet manufacturing standards that any other medical product would need to meet, and also not willing to do the really difficult clinical work that would guide treatment of their product. And I think we really need to start setting standards so that those two things can happen. One, there are manufacturing standards that are put in place, and two, there's some way to incentivize these companies to do research. So now I'm going to talk a little bit about data for informed treatment and what we don't know versus what we do know when we have to make a really difficult decision when we don't yet have full clinical trial data. And I'm talking about mostly artisanal preparations, because in the case of the pharmaceutical Epidiolex CBD preparation, there is a lot of data to guide treatment. So what we don't know is what a safe and efficacious dose of artisanal preparations are. We don't know which pediatric syndromes are most likely to respond to these artisanal preparations. We don't know what the efficacy would be. We don't know what the risks of adverse events of THC in a seizure-prone brain are. As Dr. Patel mentioned, there are a couple preclinical studies in animal models that shows that THC could exacerbate seizures. And one point I want to make here is that it's not uncommon for even FDA-approved anti-seizure drugs to exacerbate seizures in certain epilepsy types. And so that's important to keep in mind, because adverse events due to THC wouldn't necessarily preclude its development as an anti-seizure drug for a specific type of epilepsy. We don't know what the long-term cognitive side effects of CBD and THC use in a developing brain is, but this point comes up a lot, and I would argue that we actually don't have that data on many of the FDA-approved drugs that are currently given to children with epilepsy very commonly. We do know what a safe and efficacious dose of CBD is. We know this from GW's work, and we know what the efficacy of CBD in 2 specific pediatric epilepsy syndromes are, and those are the syndromes that Dr. Patel talked about, Dravet syndrome and Lennox-Gastaut syndrome. We do know what the side effects of CBD are in healthy adults and in the pediatric patient population. We know this from GW's work and also from published data on CBD. We know what the side effects of THC are in healthy adults and in adults who have a disease. There have been a lot of published studies on various forms of medical cannabis that have reported side effects. We know that artisanal CBD preparations do contain THC, and just as a general guideline, if you're looking at a 100 milligram dose of CBD from an artisanal preparation, that 100 milligram dose of CBD will also contain anywhere from 3 to 5 milligrams of THC. And these are products that are labeled CBD or hemp oil, and they're not labeled for their THC content. Again, we know that there's preclinical evidence that supports an anticonvulsant effect of THC, and we have epidemiological studies that show that cannabis use results in fewer hospital admissions of patients with epilepsy. And we also know, and this is a really important factor to consider for treatment-resistant pediatric epilepsy, we know that uncontrolled seizures result in a very, very poor outcome for these children. So let's take everything that we've presented that we do know and that we don't know and try to apply it to patient-centered care, where the goal is to provide the best possible care to each patient. And one point I want to bring up is the relevance of the 50% responder rate or seizure frequency reduction in a given patient population. And I think this is really part of a much larger national discussion on the relevance of certain randomized placebo-controlled clinical trials on the patient sitting right before you. So I think we all want the FDA, randomized placebo-controlled trials for a certain set of information. But when a doctor makes a decision about how to treat a patient, the patient sitting before him or her, that doctor takes into account much more information than is just provided from that randomized placebo-controlled trial. And so I think we have to keep considering that each patient is an individual case, and we have to try to do our best to do a risk-benefit analysis for that particular patient. And for the purposes of this discussion, I'll just provide 2 examples about why I think it's so important. We've presented to you the risks of using artisanal cannabis preparations. There are risks involved, and those should be acknowledged. There's a potential benefit involved as well, which is seizure frequency reduction, and then maybe quality of life improvement, which we can't forget about. And quality of life improvement could be behavioral improvements or improvements in sleep quality, even without seeing seizure frequency reductions. If you get better sleep, that can have a huge impact on the family's quality of life and on the patient's quality of life. So the point I want to make with this slide that's so important is that for each patient you're doing a risk-benefit analysis. Now if you're presented with a patient who, like my son, who's now 7, has suffered from an incredibly high seizure burden and has not seen any effect of approved anti-seizure medications, ketogenic diet, surgery on the progression of his disease, it might be worth taking the risks associated with using an unapproved artisanal preparation, and the benefit to him might be worth it. Now, if you're presented with a patient who's 8 years old, presenting for the first time with a seizure type that has an approved medication that actually works very well for that particular seizure type with a pretty benign side effects profile, I would say the risks of trying an unapproved artisanal medical cannabis preparation is probably not worth it. And so that's what I mean by patient-centered care and having a really rational, informed discussion about the risks involved with medical cannabis preparations and the potential benefits. And I would strongly recommend that we all start having this conversation in a rational manner, because it's become a polarizing, irrational discussion, I think. And the last point I want to make with this slide is that again, we're in this unprecedented situation where the patient has been given access through state regulations to a potential medicine without needing a physician. But the danger in not working with the physician, especially in the case of epilepsy where the physician is really highly trained and highly skilled in dealing with a really debilitating, potentially chronic illness. The danger of not working with your physician is that outcome for the child will not be as good. And so even though patients have been empowered and given access to what could potentially be an effective medicine for their children, I think the role of the physician is still incredibly important in ensuring the best outcome for the patient. And then on my last slide, I just wanted to talk about the elephant in the room, which is that I've been working in this field since 2012, so it's been 4 years, and we have no more data on these artisanal cannabis preparations than we did 4 years ago, and I think that's a real shame. And so the elephant in the room is how to make sure that we can start to collect the data that will inform treatment even of artisanal cannabis preparations. And again, we'll have to push for manufacturing standards of these products because you can't gather meaningful clinical data when you don't know what the active ingredients are and when you don't know what you're giving your patient. So we need to start holding these manufacturers accountable for their manufacturing practices and for their products. And this is something that I lobby heavily for at every level, but because access is given at a state level, there has really been no involvement at the federal level to regulate manufacturing practices. And so along these lines, company-sponsored clinical trials are very unlikely. They haven't been happening. I've not seen a single US-based company step up to do clinical work. And so we'll have to figure out a way for national institutions, patient advocacy groups, physician groups to collaborate on these data collection efforts. And I'll leave you with that thought, and thank you very much.
Thank you, Dr. Jacobson. That's really key and important, little-known information for parents and caregivers considering this. And we have a few questions that have been posed, and we'll save those for the end, but just wanted to also point out to any participants, if you have any questions for Dr. Jacobson or Dr. Patel, or for our next presenter, as soon as I introduce her here, please type those into the chat, and we'll go over those at the end of this webinar. So our third presenter today is Nicole Villa. Nicole serves on the board of directors for the Dravet Syndrome Foundation. The mission of DSF is to raise funds for research for better treatments and a cure for Dravet syndrome, a severe form of epilepsy that begins in infancy. Prior to caring for her 11-year-old son who has Dravet syndrome, Nicole studied chemistry and physics at Carleton College and the University of Minnesota, then worked for a chemical company and taught science for several years. In addition to her work with the DSF, she volunteers with the Epilepsy Foundation of Colorado and enjoys skiing and hiking in the mountains. Thank you, Nicole, and we're really grateful for your participation today.
Thank you, Stacia. I appreciate that, and thank you to Dr. Patel and Dr. Jacobson for that great intro. It was very educational for all of us, I hope. And now we're going to jump ship a little bit because my approach to cannabis as a leader in DSF is very different from my approach as a parent. So it's a lot easier to take risks and to try new things such as artisanal preparations and et cetera when you're dealing with your own child than it is when you are looking out for hundreds of children. So I will start out with a little disclaimer that my cannabis journey started in 2012 when I started treating my son with Dravet syndrome with cannabis. And fortunately back then there was nothing like this available to us. There were no artisanal preparations, there was no Epidiolex, there was no research, there was nothing. And so I have to just take my hat off and congratulate everybody that's worked so hard in the past 5 years, because just the amount of information that has been presented today is leaps and bounds ahead of where we were in 2012. So now, speaking as an advocacy group, our role in this conversation is kind of ill-defined. We are definitely involved in the conversation because our patients are using cannabis in various forms, both with and without doctor knowledge, and on both sides, both the artisanal preparations and the pharmaceutical grade preparations. At the same time, we know firsthand the struggle between what a doctor can safely recommend and the hope that parents' reports bring. So back in 2012 when CNN aired the first special on Charlotte Figge, many caregivers misunderstood the message and thought that it was a cure, that she was seizure-free. And while she's not seizure-free, she is drastically improved. And the momentum from that special led to the formation of several cannabis activist groups, each urging its own agenda. And so the patient advocacy groups kind of had to step back and decide whether we were going to get involved in that conversation then or whether we were going to wait for a little bit more research. And one of the ways that we evaluate what we're looking at as advocacy groups is we look at our mission statement. And if cannabis can treat symptoms to some extent with fewer side effects than other medications, then the impact on quality of life definitely falls within most patient advocacy groups' mission statements. So Dr. Patel and Dr. Jacobson both touched on this a little bit. Is cannabis a cure or is it a treatment? Back in 2012, lots of people were calling for cannabis as a cure, and they were really trying to get advocacy groups on board with trying to promote research, trying to urge legislation, trying to really advocate for them because they thought it was a cure. And over the past 5 years, we've come to see that it really is a treatment. We don't know how efficacious it is yet. There's good evidence that it might be a good treatment, but it's definitely not a cure. And so when we think about what a patient advocacy group does, we have to keep that question in mind, that we might put a lot of research, support, and awareness and education into something that has the potential to cure our population. We might put less of our resources into something that might be a treatment. So different patient advocacy groups have different missions, and most of them fall into some proportional conglomeration of these four things. They support research, they offer support to patients and families, they offer education, or they offer awareness. And a lot of times advocacy can fall into both awareness and education. We here at Dravet Syndrome Foundation really focus on research. In fact, when we first created in 2009, our only mission was to support research for treatment to cure. Obviously, we've expanded that over the years, so we now do support and education and awareness as well. Other smaller patient advocacy groups like Lennox-Gastaut Foundation, the Rett Syndrome Tuberous Sclerosis Alliance also focus on research, and they might have arms that will help with support and education and awareness. The big difference between the smaller patient advocacy groups and the bigger ones like the Epilepsy Foundation is that smaller patient advocacy groups often don't receive a lot of national funding or for their specific disease. So the Epilepsy Foundation, for example, encompasses a lot of different epilepsy types. They get a lot of funding from NINDS, from NIH, for epilepsy research. Dravet Syndrome Foundation doesn't get funding from at the national level specifically for Dravet. There might be some studies done on Dravet that are funded nationally, but we don't have any dollars really allocated to Dravet syndrome. So it's easier for things like the Epilepsy Foundation to be more proactive in supporting awareness and advocacy when it comes to things like cannabis than it might be for some of the smaller ones. So just highlighting position statement excerpts here. Most of the patient advocacy groups have some statement on CBD. We here at DSF are interested in promoting research into safety and efficacy. LGS acknowledges the anecdotal studies but wants more research done. And Rett syndrome goes a little bit farther and wants dosable information about cannabinoids before they can even endorse the use. So when you talk about research in patient advocacy groups, there are a couple different ways that we can support research as a group. We can offer grants, that's the most direct way, and some advocacy groups have done a better job of that in the past 5 years than DSF has. In 2014, CURE supported a $250,000 grant into the mechanisms of CBD. And this year in 2016, DSF was able to continue funding of that grant. The other way we can encourage research is to encourage our patients to participate in clinical studies. And there's been a lot of information on that Epidiolex, or on those Epidiolex clinical studies, and those are wonderful sources of information. But there are other clinical studies out there that patients can participate in, even if they're not on Epidiolex. We here in Colorado were lucky enough to receive state funding for 2 grants that sponsored clinical studies of use of artisanal products here in Colorado on children, where children were enrolled and their parents were able to choose what kind of cannabis they were given. So sometimes it was Charlotte's Web, sometimes it was Haley's Hope, sometimes it was whatever the parents made in their own kitchen. And there were 2 studies, one published in 2015 and one recently published in 2016. And Dr. Patel touched on that 2016 one that reported that oftentimes parents go into this thinking that it's going to be a cure or that there will be a lot of reduction in seizures, and they're oftentimes disappointed because there's not as heavily of a reduction in seizures as they thought there would be, and they tend to terminate use before the year is up. So when you go on to other missions or the other parts of patient advocacy groups' missions, you can talk about support. And support can take a lot of different forms. One of the ways that DSF supports our patients that are using cannabis is through our support group that has over 1,700 members. And there are a lot of conversations about cannabis in that support group, and we support those conversations. We do not limit it. We do not limit it to certain products. We do not limit it to only things that are not FDA approved but that are going through clinical trials. We talk about it all, and we hope that our parents feel free to talk to us. However, as Dr. Jacobson touched on, there can be some factionization happening, and some people who support one product will disagree with the lobbying efforts of people that support other products, and for that reason, there are several other cannabis-specific Facebook groups. Pediatric Cannabis Therapy is probably the biggest one. It can be a little contentious at times, but it's a great place for information as long as you are able to weed through a lot of dialogue. The Epilepsy Parent Cannabis Support is also a good one. It has over 1,600 members, and there are all sorts of other cannabis groups out there that can offer support. When you talk about awareness and that component of a patient advocacy group's mission, I would argue that Charlotte Figge and her use of cannabis has brought more awareness to Dravet syndrome than DSF has brought to the cannabis movement, and that's okay. Other groups are better at doing awareness, like the Epilepsy Foundation. They have a 2016 press release on the refusal of the DEA to reschedule cannabis. They have supported the CARES Act. They have a Speak Up and Speak Out network where you can join the advocacy campaign. And one thing to point out is that lobbying groups are often too varied in focus for us to get involved with a single campaign. So it's hard for an advocacy group to support CBD-only legislation in a state, for example, or to support whole plant legalization, or to support the various bills that have been brought to the House. And it's also hard for us to support complete descheduling because we don't have enough data out there to know which of these avenues is going to be best for our patients. And so when patients are calling on us to support this or support that, we have to make a very conscientious decision and look back at our mission statement and say, does this fall within our mission? And oftentimes it doesn't. When it comes to education, there is a lot more available now than there was in 2012 when I started treating my son with cannabis. The thing to look for when you are looking for educational sites, however, are that you want to know that what you're reading is reliable information and that it is not biased by a company. So I have 2 screenshots here from GW Pharmaceuticals education portion of their website, and they are okay. They explain a little bit about CBD and THC. They attempt to explain a little bit about how those might work with the receptors and the neurotransmitters and the synapse between neurons, but they're also a little bit vague. The good thing about these GW sites are that they are cited, and that's one thing you want to look for when you are trying to educate yourself on cannabis. If you are reading an article and there are citations at the end of the article that you can go to fact check that article, that's a good sign. It's not the end-all be-all. It doesn't mean that that information is all accurate because, as we all know, you can find sources to support whatever you're trying to say, but it's a good sign that this is not just something that someone has made up. The Epilepsy Foundation has a good section on the legality and what exactly is legal and what exactly is illegal. And the Realm of Caring has a good orientation series. They have an extensive research library, and they have resources for patients. The one thing I would caution when you go to sites like Realm of Caring is that there are very few resources that suggest that it might not be beneficial to the patient. So things like the Colorado studies where they were looking at parents' perception of how cannabis is working in their child, those wouldn't be listed on the Realm of Caring site because they're not 100% beneficial. So the last thing I want to touch on in the interest of keeping you guys not too long is what is your role in the conversation? So when I say your, I'm talking mostly to patients because that's who we represent, but it could be as a provider as well. What we have to remember is that the patient is responsible to become educated on the topic. And that might be asking your doctor, it might be asking for a second opinion, it might be looking on your own on the web, it might be talking to other parents, but it really is the patient's responsibility to be educated in the treatment of their child. It is also the patient's responsibility to participate in research where possible. If we are all treating our children with cannabis and not sharing that data or those experiences anywhere, we're not helping move the knowledge base forward. It's also the patient's responsibility to talk with your doctor and choose the right options for your family while also respecting the views of other families. So obviously not every patient is successful in this treatment. My son was the second child on what's now called Charlotte's Web, and it didn't work for him. In fact, it questionably made it worse. And that's okay. I still respect everybody else's choice to use cannabis because I see it working in other children. I respect the families who choose not to because they're not ready or the research isn't there yet for them. That's okay. The other patient responsibility is to support each other. As an advocacy group, we also have responsibilities. As Dr. Jacobson touched on, we need to fund research, and thankfully that is moving forward a little bit. Dr. Patel mentioned that it's difficult to get government funding for cannabis research because of the DEA scheduling, and so some of that research might need to fall on advocacy groups. It's also our responsibility to encourage our patients to participate in clinical studies. I think patients don't always realize that they are a key component to research. Oftentimes they think research is happening in a lab somewhere or at a desk somewhere, and they forget that it's their job to bring their experience forward. It's also our advocacy group's responsibility to moderate support networks effectively, meaning to encourage conversation and encourage support amongst parents, and to increase awareness of the disease and the lack of treatments for the disease, and also to support all families' decisions. So with that, I will turn it back over to Stacia, who will moderate the question and answer portion of the program. I want to thank Child Neurology Foundation for hosting this webinar for us. I think this was a great introduction for families who are thinking about cannabis and how they might be able to use it.
Thank you, Nicole. And yeah, your presentation really had some great practical next steps for parents and caregivers who want to move the conversation forward with their provider or get more involved in advocacy. So thank you so much for that. We do have about 10 minutes for questions, and we've had some that's come through the chat feature. I wanted to just get this one out there, as Charlotte's Web has been mentioned several times. And somebody asked, are Charlotte's Web and Haley's Hope reliable sources to obtain CBD oil?
I think it's really hard to answer that question because so the way I would answer that is I would take 3 different Charlotte's Web bottles and 3 different Haley's Hope bottles and have them all tested at 3 different labs and see how the chemical composition varies and or relates to the labeling. So my personal experience is that neither Charlotte's Web nor Haley's Hope is accurately labeled, and that there's variation from batch to batch. But I know that they're both very successful businesses and that there are a lot of families out there that rely on them. If I were to consider giving something to my son, I would just have it tested multiple times, and I would have to have every bottle tested.
Now, this is Anouk Patel. I would agree with what Dr. Jacobson said, that to answer that question accurately is really we don't know, and I think that's the biggest problem. We just don't know. And the unknown, I think, is what bothers me the most. All I ask of those companies, like anything else, like Dr. Jacobson so eloquently stated in her presentation, is just do what we would need to produce and show that these products are what they say they are. And as long as they do that, I would support them wholeheartedly. But until that day happens, it's hard to answer these questions for the safety and benefit of our patients.
Nicole, do you want to chime in? I know you already mentioned that you didn't have the greatest success, but do you have anything else you'd like to add?
I would just add that I agree with them. I would say that Charlotte's Web and Haley's Hope are probably the most reliable artisanal ones you're going to find out there. You're going to have the best shot at getting something consistent with them, but that does not guarantee their consistency, like Dr. Jacobson and Dr. Patel mentioned.
Thank you all. Dr. Patel, this question came in during your presentation related to the Dravet study, and somebody asked, was the type of SCN1A gene mutation known in the Dravet study? Was there a difference between kids with splice site, missense, or non-sense mutations if it was tracked?
So that is an excellent question. A majority of the patients in the Dravet study did have a mutation within the SCN1A gene. However, to my knowledge thus far, no further analysis has been done on the specifics of that mutation. I think that would be a great analysis point moving forward, and I think that's another area of emergence in our field of pharmacogenomics and how we can specifically apply some of the details of the mutation or variation in the gene and how that can be applied to treatment. So right now the answer is majority of them did have SCN1A. It was not a requirement. They had to have the clinical presentation of Dravet, and that was confirmed by an independent consortium. So people would have, like for us to be participating in the study and to get a patient included, we would send all the clinical and lab information to an independent consortium who would agree on if they had Dravet or not Dravet. And again, most of those did have SCN1A, but that was not a requirement, but we'll have to see moving forward if there's a specific signature within, if it's a missense versus nonsense. So great question, but unfortunately not a great answer right now.
Thank you, Dr. Patel. This one's for Nicole or Dr. Jacobson. What would the number one message you want caregivers to take away from this webinar be as parents?
Well, my answer would be to be open-minded and to do that risk-benefit analysis with me as the child's parent, to help me do the best risk-benefit analysis I could do in determining what the best treatment option is going forward.
Yeah, it's really, this is a personal choice for parents, and it's a personal journey as well, because unless you're in a clinical trial, you are going to be going down an uncharted road. And just for parents to know that they're going to have to take a lot more ownership of this treatment should they decide to do this, I think that it's a big step for parents to make.
And for those parents that are new to this path or this consideration of treatment with medical cannabis, is there anything that either of you wish you would have known when you first started to consider the treatment for your son?
I wish, Nicole, I wish I had known, there was no way to know back then, but I wish I had known that it might not necessarily work, because I struggled with CBD for over a year trying to get it to work in my son, and I gave it a lot longer than I would have any other medication that a doctor had suggested I would try. So I wish I had been more aware of the potential for it not working.
Dr. Jacobson, would you like to chime in? Otherwise, we have another question here for Dr. Patel.
Well, I think I just wish we had more information. I think I wish I had known not to trust the dispensaries right away. I wish I had been able to figure that out before testing these products on my son. I wish I had known that there might be reliable people to talk to. Yeah, I wish I had been more discerning on who I got my information from.
Well, thanks to all of you for the great work that you're doing in advancing the education and the research, because those are the first steps and where we begin in moving that forward. So thank you. So Dr. Patel, what's the best way a parent has approached the conversation about medical cannabis with you? Are there any strategies that you appreciate as a physician if a parent uses?
Yeah, I do. I'm glad you asked that question. I think honesty is the most important policy. Unfortunately, not everybody may be open to the discussion, or at least the pros and cons of what is going on, but I think it's very important to have a honest and open dialogue, because no matter what you're doing, it might have an effect or influence on what I'm doing or recommending as a physician as far as the treatments go. And so I think that's the number one approach. And then just to be open and honest about, everyone has their own approach, information. And so what else I find to be useful is if you do interact with somebody that may not be as knowledgeable. I have the fortune of being knowledgeable in the sense of participating in the studies, et cetera. But I understand that, not all of my colleagues may be as open or at least knowledgeable in the area. And so I think what's helpful is just to understand where somebody's perspective is going, and just to understand that it's a two-way communication, and really what we want in the end is the common goal. And to understand, I guess that would be my final message, is to understand that honestly all of us in the medical community and all of the parents and caregivers and patients all want the same, is we want what's best and safe and what works the best for our patients and for those people who have epilepsy. And we're in it together, and we're really in it to fight the same battle. And so let's work together.
Dr. Patel, and we are at the end of our time for the webinar, but wanted to give Nicole and Dr. Jacobson a chance to add any closing comments. Nicole?
I would just close with a little bit of encouragement. I've been kind of down about this, but the evidence is out there that CBD can really help in in some types of epilepsy, and awareness and studies and research and manufacturing have all come leaps and bounds from where they were 5 years ago. So we're on the right road, thanks to everybody like you got, like CNFs and Dr. Jacobson and Dr. Patel and their work. So just close with some encouragement that this is going in the right direction.
Thank you, Nicole. Dr. Jacobson?
I think I would really echo Dr. Patel's message that while caregivers and patients are empowered to choose the products that they think might help, I think it's really important to find a doctor that you can talk to openly and honestly about it, and who will work with you even though that doctor may not be able to prescribe it for you. Tracking the patient and coordinating all the other aspects of the care along with the artisanal preparation is really critical to ensuring a better outcome for the child. And some doctors are going to be more open than others, and you just have to find one that you can work with if this is a path you want to go down.
Thank you for that. And a thank you to all of our presenters and participants for joining us today. CNF is truly grateful for your contribution to the child neurology community and for the opportunity to work together to really improve the quality of care and the quality of life for these children that we all care so much about. So happy holidays to you and your loved ones, and have a wonderful day.
Thanks.